All right, so welcome everyone to Project Echo. Today is Wednesday, December 17th. And for today's discussion, we will have Dr. Cody Chastain present on hepatitis B serology, interpretation, and management in people with hepatitis C virus. We will have two case presentations and hopefully an opportunity at the end for additional questions and answers if you have them. My name is Lindsay Zimmerman. I am the Viral Hepatitis Prevention Director with the Tennessee Department of Health. Although our Project Echo is run out of the Tennessee Department of Health, I do want to emphasize that we are community driven. So we welcome any and all external partners in addition to our internal partners. Just a reminder that if you are a provider, nurse, social counselor, anyone interested in receiving a continuing education credit, please make sure that you have registered through the Southeast AIDS Education and Training Center. You can use the QR code on the screen or the link. In order to receive the credit, you do have to attend the full session. This particular registration is separate from participation in Project Echo. If you do have specific questions about it, contact information will be added at the end of today's session. You will, once you attend the full session, you will complete a post-session evaluation, and then your certificate will be emailed to you at a later time. We do still have some folks joining, so I'm going to pause for just a moment. All right, we can go ahead to move to the next slide. Just some reminders, Kimber did drop her information in the chat, but if you do have technical issues during today's session, please private chat Kimber Miller. Again, her contact information is in the chat. And I think I just admitted the last couple of people that were joining, so we will continue to do so if others join. But otherwise, Dr. Chastain, I will go ahead and turn it over to you.
Great. Well, thank you all so much for, again, hosting this at TDH and inviting me to speak. For those of you I haven't got a chance to work directly with, I'm Cody Chastain. I'm an infectious disease physician at Vanderbilt University Medical Center and also the principal investigator for the Southeast AIDS Education Training Center. And Melissa, I'm going to try to share a screen after I get permission from one of our team members. And I'm actually going to share the exact same slides, but from a slightly different way. Lindsay, are you able to see my slides yet?
Yes, I can.
All right, perfect. Well, the reason I moved it to this slightly different view, you can see at the very top of this slide that we'll be using some audience response. You can certainly come off mute. You can certainly use the chat box. You can use other normal Zoom features. But if you want privacy and you want anonymity to answer a few questions, I'll provide that in a different way. So we're going to talk about hepatitis B serology, interpretation, and management in people with hepatitis C. This is, I would say, an intermediate topic. Sometimes on echo programs, we talk about basic evaluation, the initial selection of therapies for people with hepatitis C, whether it be pediatric populations or whether it be adult populations. This is where I would say is kind of more in the medium category. Not that it's too advanced for this audience, but something that's sometimes the next step in what we think about with taking care of people with hepatitis C. I don't have any conflicts of interest or financial disclosures pertinent to this topic. I do want to highlight that I received funding from DHHS HRSA as part of the Ryan White program, Part F, as the principal investigator for the Southeast AIDS Education Training Center. This is the formal disclosure that we are always encouraged to provide when we speak on behalf of the AATC. And I'll just highlight that that my views do not necessarily reflect the official policies of DHHS or an endorsement by any other group. So this is what I'll highlight that you should be able to do at the end of our 15 to 20 minutes together here this morning. You should be able to do two following things: interpret hepatitis B virus diagnostic testing And you should be able to describe how hepatitis B virus co-infection impacts the management of hepatitis C. So we'll focus a lot on diagnostic testing and serology interpretation, but I think it's also naturally most of our programs focused on hepatitis C management and treatment. So how does that hepatitis B data and or diagnostics make an impact on what we do next when we're evaluating, assessing, and also treating people with hepatitis C? So my hope is that wherever you're at, we can take you to the next level. And so again, if I'm aiming too low, you can ask follow-up conversations or questions in the chat box, and we'll make sure that we have time for those. And if for some reason I'm not clear in what I'm presenting, we'll make sure that we come back to the right topics at the right places. So some of you have already done this because I can tell from people logging on below. I'm going to give you two different options. All of you are connected either to your phone or computer, so I know you've got the technical capabilities of doing this. If you want, you can actually use your phone or a separate device and scan that QR code on the right side. That means the questions and the audience response will come up on your phone for the remainder of the program. Or since I know that many of you are working on a computer, you can actually open up an additional window and go to Menti, www.menti.com, and then it'll ask you for a code. And you can put the code 99478316. Move on. That means that there'll be opportunities for you to give some short answer or follow-up questions, but also to participate some anonymous Q&A polls. Here, again, I'll also take an eye and keep an eye out for things like in the chat box and other functions. And so we got several of those different opportunities. And so again, want to make sure that you all just know that you can interact and engage in any way you want to, but want to give you all the options. All right. So I want to highlight that I'll start here from the ground up. Our simplified guidance is something that we refer to frequently in this program. The American Association for the Study of Liver Diseases and the Infectious Diseases Society of America produced these one-page documents, which now spill over slightly over to 2 pages for each of these several years ago. And this is all about simplified hepatitis C treatment for those who have never been treated before for hepatitis C, and those without cirrhosis and those with cirrhosis. But it's amazing that we can basically capture 98% of what you need to do for people with hepatitis C on these documents. That being said, in that top section, there is a call out in both of these documents about who is eligible and who is not eligible for simplified treatment. And I want to highlight for the purposes of this conversation that hepatitis B surface antigen positive individuals are ones that we need to think a little bit more about, and we have to potentially take some extra steps in order to advocate and to safely manage. And so just setting the ground rules, simplified guidance is fantastic. But when we talk about hepatitis B, particularly surface antigen positive patients, this is a group that we sometimes think a little bit differently. So to ground this in a case, let's talk about Sally. Sally's a 28-year-old woman who's diagnosed with hepatitis C. She's recently diagnosed after intake into your program, whether it be a primary care program, whether it be a substance use disorder treatment program, or another setting. Past medical history, she has a history of prior injection drug use that included opioids and cocaine, takes no medications, has no known allergies. She has no known family history as she was adopted. And from a social history, she does smoke a half pack per day, does not drink any alcohol, and previously used substances, but is currently in remission. Hepatitis C testing reveals a positive antibody non-reflex 15 million copies per drop of blood or milliliter with genotype 3. Physical exam is unremarkable, and her other labs reveal mild anemia of a hemoglobin of 12 and hematocrit of 36, a platelet count that's in the normal range of 375. She has a creatinine or kidney function that is in the normal range, but she does have moderate inflammation of her liver, an AST of 95 and an ALT of 185. The upper limit of normal for both these are usually 40, 45, or 50 on different laboratories across country. She has normal synthetic function. Her per thrombin time or international normalized ratio for bleeding time is 1.0. But her hepatitis B serology is abnormal. For HIV serology, thankfully, is negative or normal. And you do have access to transient elastography to assess how much scar tissue is in the liver. And great news, she has minimal or no fibrosis. So emphasizing that hepatitis B serology is abnormal. My first question for you is what additional information do you need to know regarding hepatitis B virus to manage this person's hepatitis C? And so everything goes here. So this is the first opportunity to put things in the chat box. In Zoom, you can come off mute on Zoom. You can also use Menti if you've logged in there to drop in some comments about what additional information you would want about Sally's hepatitis B abnormal serology. All right. So one question is like, what's the surface antigen status? Is it abnormal? And so how has the patient been vaccinated? Someone followed up almost immediately. Hey, well, vaccination history. Uh, Hepatitis B genetic material. How is it detectable? Is it manageable? Is there evidence of active hepatitis B infection? Uh, Rajiv mentioned in the chat box on Zoom, a surface versus core serology test to actually differentiate what type of immune response is present. Has she ever been aware of a prior diagnosis? Is she actually on treatment for hepatitis B? These are all fantastic points. And so I think that this really has questions like, well, what additional information do we have in this regard? Now, is there IgM positive, a surface antigen positive? So getting back to this idea of like, well, what diagnostics? And somebody who has been in this area long enough to see lots of different varieties or responses, what does equivocal mean when you see an equivocal result? I'll take a sidebar on that. Equivocal in a laboratory interpretation means that there is some reaction, whether it be to an antibody or to an antigen test, but not enough to actually surpass a level that would give you a definitive positive. And there's something that is actually responded, so it's not a negative. We typically see equivocal results sometimes reported for antibody responses. And so what it really means is partial information. Uh, Another person asked us like, well, no, do we have a timeline? Do we know the acuity? All these are great points. And so well, I'm going to put you through the ringer here just for a minute. Let's just pretend we have a couple different scenarios for Sally. How would you interpret this serology? A lot of times we get triple panel testing, which includes a core antibody, HBcAb, a surface antibody, HBsAb, or a surface antigen, HBsAg. So how would you interpret this? Negative core antibody, positive surface antibody, negative antigen. And again, we'll give you some anonymity here. If you want to put something in the chat box, if you want to come off mute, you're more than willing or able to do that. But this gives you an opportunity to do a multiple choice option and see where your dot fills. I will admit, I also love using this type of technology when I do things like medical student lectures and other things. There is wisdom in the crowd, but there is also the potential for some lemming effect where you get enough people to answer the wrong answer and everybody flocks to the wrong answer because of the peer pressure. All right, so this is a core antibody negative person with a positive surface antibody and a negative surface antigen. So we've got 9 people here. So this is immune due to vaccination or immunization. Now 10, now 11. And we've got a couple who are suggesting this might be due to active infection, and one suggesting it might be due to immune due to natural infection. So hold on to that thought, but let's go to another place in the multiverse. And we actually have Sally, who has a different serology profile. HBC antibody positive, HBs antibody positive, and HBsAg or antigen negative. So different multiple choice question, different multiverse, core antibody positive, surface antibody positive, surface antigen negative. And again, the exact same 4 options: active infection, immune due to natural infection, immune due to vaccination, never exposed. And we got about 15 players or so that were sticking in with us. So I'll give a couple more seconds here to see if we get some latecomers. We'll Don't let the enthusiasm wane here. We got a couple people who are suggesting active infection. The bulk of the crowd is suggesting immune due to natural infection with a core antibody positive, surface antibody positive, and a negative surface antigen. And then the last one I will challenge you with is how would you interpret the following serology? A core antibody positive, a surface antibody negative, and a surface antigen positive. So again, the last variation I will pitch to you. How do you interpret the following serology? Core antibody positive, surface antibody negative, surface antigen positive. Again, I think we landed around 15 or so. Um, Give you about 10 more seconds. All right. So, what I'll just kind of reflect with you, what we're going to do is march through these three tests. You notice I did not have hepatitis B DNA or RNA listed. You can get DNA routinely in the a standard laboratory. RNA is really only a research-based test when it comes to hepatitis B. You often think about hepatitis C RNA because that's our standard test, but hepatitis B DNA is usually what we obtain. The vast majority of the time, this is what's going to be available on a triple panel test. And that's what actually the CDC recommends as far as one-time lifetime testing when it comes to non-targeted testing for people with hepatitis B. I'm going to build on this chart in the next few slides. On the left side, you're going to have the state of the person and then what the surface antigen, the core antibody, and the surface antibody response would be. But let me define what those things are. The surface antigen is a protein that is detectable as part of the viral envelope. It's actually a protein that sits within the viral envelope, and that means that there is intact virus detectable within the bloodstream. So surface antigen, generally speaking, is a marker of active hepatitis B infection. A core antibody is meaning that the human immune system has reacted to core proteins that are inside that envelope. That typically means that that person is either currently infected with hepatitis B or that they've been exposed to hepatitis B at some point in the past, because that antibody would only be generated if they've been exposed to those core proteins. A surface antibody is part of the human immune system of an antibody that might be generated against that surface antigen. It is a smart missile, an antibody that might develop against that protein that is on the envelope surface of the hepatitis B virion. So that could be as a response to either current or prior infection, but this is really, really important. The surface antibody is probably the key to actually developing clearance or immunity against hepatitis B. So it's rare that surface antibodies and antigens coexist within the same system. But also it's really important to recognize that a surface antibody could actually be a reaction against the virus, either present or past, or it could actually be reaction against a specific protein. And what do we do with hepatitis B vaccination? All hepatitis B vaccinations are currently available are surface antigen protein derivatives. So we essentially do not give a infant, a child, or an adult hepatitis B virus. We do not give live virus vaccines or attenuated vaccines. Rather, we give them a protein subunit vaccine. We challenge someone's immune system just with a protein that looks like the surface antigen. That means if you give a vaccination, what you're trying to promote is a surface antibody response. But you don't subject the person to any more virus than that. So with that framing, we can march through understanding of why these panels look. A naive person that's never been exposed to vaccination nor to the infection, this is pretty easy. All the tests are negative. They don't have any evidence of the infection. They don't have the evidence that their immune system's been primed in any way. Immune due to immunization. This is a multiverse Sally number one. A surface antigen negative, a core antibody negative, but a surface antibody positive. What we can say is that this person has never been exposed to the virus itself because there's no core antibody response. There's no evidence of the virus. There's no surface antigen. But what there is that there is antibodies only against that surface protein. And in that context, a surface antibody will be the single isolated finding that will be found on this serology. Immune, quote unquote, due to natural infection looks a lot like that, but slightly different. You still don't find evidence of the virus itself. There's no surface antigen here. But you actually find both core antibodies because that person had been exposed to the virus and the different proteins of the virus, and also have been potentially exposed to that surface protein, the surface antigen. Now, to be honest, this person could have been vaccinated at some point in the past, but what's more important than that, this person has definitely been exposed to the virus. I say immune in quotes here because in rare cases, patients can have hepatitis B reactivation when their immune system is weakened. If those antibodies drop down to zero because of medicines, whether it be chemotherapy or other interventions, that can rarely mean that hepatitis B can reactivate. And that's why I say immune in quotes. Active infection is classically associated with surface antigen positivity. That means that protein is detectable in the bloodstream. That is a protein that is part of the virus, not part of the human genome. And if you find that, we suspect that there's active virus that's present. Most of these patients, if you check a hepatitis B DNA, you will find detectable DNA that's present. Sometimes can vary a lot in how much is there, but it's typically present. Again, that core antibody can be present because, again, that means that your immune system or that person's immune system remembers being exposed to that core protein. But importantly, a surface antibody has not developed. Again, that is a key element in clearing active infection. And if you have active infection, well, generally speaking, that surface antibody is not going to be present. There are rare cases where you might see all three of these positive. That usually isn't the case where someone's had an acute infection and they are transitioning from having an acute infection to clearing that infection. And let's just be honest, there are other potential options. I focused on these top four rows, but probably the next most common variation is this, just having a positive core antibody with no antigen and no surface antibody. And there's a lot of reasons this could occur. Very low level infection. Maybe that surface antibody is faded. Maybe this is an early infection, but now it's in the midst of clearing. Maybe it's just a false positive test. So this is a guide that we've kind of walked through, but it's not necessarily definitive. Now, I want us to pause here and see if anyone has clarification questions. You can feel free to put it in the chat box or come off mute because what I'm going to do is pivot from here to talking about management of people with Hep C and different Hep B sorry, statuses.
Dr. Justine, I wanted to say I just had a scenario like the last one in the past week where I had a patient with just a core antibody. And I was also treating their partner who was positive for a previous infection with hepatitis B and C. And the patient I was seeing was positive for Hep C and then had their Hep B come back with just the core antibody. So I did go ahead and get a DNA level just to confirm we weren't in an early infection because of the concerns for extensive exposure.
That is a great, I think it's just a great point. And I would say that generally speaking, what we're worried about is that what you just highlighted, a potentially recent infection or a very low level infection, such a low level infection that doesn't trigger a positive antigen. And you did, I think, exactly the right thing is actually checking that hepatitis B DNA to check for that infection. If we then find that there's no evidence of DNA there, typically we say, well, this is probably either a false positive or this is a person who probably cleared infection, like that immune due to natural infection, but the surface antibody level has waned over time. Some people ask, what do you do with these folks? And the answer is not much. Could you vaccinate them? Yes, you can vaccinate them. And that's particularly important because it could be a false positive that vaccination is not necessary for treatment of anything. It's rather to actually vaccinate somebody who may benefit from that if you think that's a false positive. In your particular case, I think what it highlights is that a lot of times we check for active infection. If it's not there, it probably means that they were infected at some point in the past. And Lori, definitely will echo to you. I think we've all at some point been exposed to this information and or have been responsible for actually sharing with other folks. That's complicated. And so I'm glad that this was helpful. And Tinu, yes, you do this enough, that last category absolutely shows up, as long as some really weird variations, which I bet Dr. Allen, Dr. Alfaro Cruz could probably echo that. Sometimes just patients don't read the textbook. What I do want to highlight is why do we even bring up hepatitis B at all in this context? And why is there a black box warning on hepatitis C medications when it comes to hepatitis B? And that's because of this observation back in 2017 about the risk of hepatitis B reactivation when people being treated with direct acting antiviral therapy for hep C. This was actually a collection of different case reports and things that were subsequently shared post-marketing. And there were about 29 cases between 2013 and 2016 of people being treated for hep C. And there were 29 cases of hepatitis B reactivation. In those cases, two people died and there was one liver transplant. And that's why black box warnings were added for all directing antivirals. But interestingly, there was a follow-up study published just a year later in 2018 that was much larger and looked at much bigger groups of patients, looked across 17 trials. And what they found is that among all those patients treated, there were about 1,621 who had some form of abnormal hepatitis B serology, 242 with chronic hep B, those surface antigen positive patients, and 1,379 who had previously resolved hep B, those quote unquote core antibody, surface antibody positive patients. And what they found is that hep B reactivation rates were far greater in those with surface antigen positive and very, very infrequent in those with resolved hep B infection. But you might still say, well, 1.4% is not nothing. I'm still worried about that. But all of the clinically relevant cases, all of the symptoms, all of the LFT elevations, that liver decompensation, the liver failure, the death, the liver transplant, every single one of the clinically significant, not just a lab marker, but a clinically significant, all happened among people with surface antigen positive disease at baseline. It did not occur among those people with core antibody and surface antibody. So even though 1.4% of those core antibody surface antibody patients had reactivation, it was a laboratory finding only. It was not a clinical finding. It was not a symptomatic finding. It had no change in the context of their clinical care. So what this really means is, and this brings us back to the simplified guidance. If you have a patient who gets evaluated for hep C, they should have hepatitis B screening done. And if a surface antigen is positive, that is consistent with active hep B. Those are the type of patients that, generally speaking, should be evaluated for treatment, whether it be with a hepatologist like Dr. F.R. Cruz, myself as an infectious disease doctor, or by someone who has experience managing viral hepatitis. Because hep B is complicated, is that we don't have as clear-cut rules with hep B as we do with other diseases, and we don't have a cure yet. So in this context, we focus on how much inflammation is present, what status the disease is, what degree of fibrosis or other co-infections present, and that helps us determine whether to treat it or monitor it. What I would just simply say, a person with surface antigen positive disease, those people deserve to have a thoughtful evaluation by someone who manages hepatitis B. I'm not saying they can't be treated for hepatitis C. Not saying they can't be treated effectively. It just takes you off that simplified guidance page and say, I need to make sure that someone who is used to managing folks with this condition are involved in their evaluation and care. That's actually not the majority of folks you'll take care of, though. The majority of folks that you run into problems with hep B serology are patients who do not have active, they'll have a negative surface antigen, but they might have a positive core antibody. Remember, those are the patients who might have prior exposure, but those are the patients when those big studies did not show clinically significant reactivation. I would say that those patients can be treated for hep C. Those are not patients who are ruled out by simplified guidance. But some people argue that additional monitoring should be done for those patients. And that might be those are the patients that should have week 4 lab tests and should be counseled that if they have any symptoms while on therapy, they should reach out. And I would simply say if you have elevated liver function tests or symptoms while on hepatitis C therapy, hepatitis B testing could be reassessed at that point. So my general tips is treat active hepatitis B as you would any other person with active hepatitis B, regardless that they have hep C. But that should be done in concert with experienced provider expert. And Project Echo and this particular program can support you if you have a co-infected patient and how to manage them or to engage for other aspects of care. Don't withhold hep C therapy if a person has resolved or inactive hepatitis B infection, but do consider closer monitoring in those patients. And so my email's at the top. I'm going to pass it back to Melissa to actually share, but I'll pause here for questions from Lindsay or the crowd. Feel free to put it in the chat box or to come off mute.
I agree, Dorinda. Dorinda's put in the chat. That was a great overview. I really think that highlighted a great summary of hepatitis B, an active infection, but also how we can apply that to current treatment.
Could I
Does
ask a
anyone?
question?
Sure, go ahead, Bill.
Now, typically when patients, if you had a surface antigen positive, you ran your IgM, the patient has a positive IgM, they're also co-infected with hepatitis C. The patient is not cirrhotic. Do you start them on, do you give them entecavir or tenofovir? Because typically if they had Hep B alone, uh, most of the guidance I've seen uh, says you don't necessarily start someone when they're in the acute phase. So granted, I'm going down a weird, one off here, but would like to get your comment on
Yeah,
that.
it is not a one-off bill, and I always appreciate the thoughtful questions. And I think this is a real tension point, right? Sometimes we have patients who are engaged in care, clients engaged in care. We want to make sure we maximize the resource available, whether they're in a carceral setting, whether they are in a substance use disorder setting. And this is where I think some of the tensions come into play. Hep C, we have now moved to the point that whether you have acute infection or chronic infection, we recommend treatment for everybody. And this particularly when they're engaged in care, the quicker we get them treated, the better it's going to be for their health and for also public health. Hep B is a little bit different because acute infection is the period of time where immune reaction, immune reactivity against the virus actually promotes the greatest chance of clearing the infection. If a person's going to spontaneously clear the infection due to immune activation, it usually happens in the first 6 months. If you blunt that inflammation by removing the source of inflammation, such as by giving a antiviral therapy, there is some data to suggest that yes, you can bring down the hepatitis B, but by doing that, you also might limit the degree that the immune system will respond and actually reduce the likelihood that person might be permanently cured by their own immune activation. So that's a tension. The other component of this is like, well, where are they going to be in 6 months? In 6 months, are they going to be out of your system? Are they going to be able to get Hep C therapy? That's another factor. And I think what, though you also very thoughtfully brought up, is patients with active Hep B, surface antigen positive disease, we generally recommend treatment of their hepatitis B concomitantly when they're treated for Hep C to reduce the likelihood of hepatitis B activation. But treating their Hep B in that scenario that you just mentioned, a person with recent infection, as evidenced by their IgM positivity, you could be facilitating safer treatment of Hep C while also decreasing the likelihood of them clearing their Hep B. And so I think that ends up being a value judgment. How confident are you that this is truly acute infection? Do they have recent risk factors? Do you have prior diagnostic tests? Are we confident that IgM actually reflects acute infection? Um, where are they going to be in 3 months, 6 months? Can you get follow-up testing? Those are all factors I would consider when trying to manage someone with Hep B, Hep C co-infection who might have an acute. The takeaway points for the group is we do not treat all patients with Hep B. Early treatment of Hep B could actually negatively impact patients from spontaneously clearing through immune activation. But if you're going to treat Hep B and Hep C together, we generally do treat active Hep B to limit the likelihood of a hepatitis B flare while we're treating with hepatitis C medications. Great question, Bill.
Hey, this is David Kershke.
Hey, David.
Hey, so providers that I work with have been told by another preceptor that if they have a surface antigen negative, core antibody positive Hep C patient to get a hepatitis B viral load on all those patients. So theoretically, if a viral load came back in a hepatitis B surface antigen negative patient, but the viral load came back positive, which I seem to recall someone said happened at some point. I don't know if that's possible or if it's, but then if that did happen, what could explain that and what would you do in terms of their Hep C treatment?
So, David, this is a great question. I'm going to link this back to Dorinda's case scenario that Dorinda shared with us. Let me give you one scenario. A patient has a negative surface antigen, positive core antibody, and negative surface antibody. That was like Dorinda's patient. That is a patient I would get a hepatitis B DNA in to make sure that there's not low level infection because something called occult infection can occur where it's not detectable based on the protein cutoffs of surface antigen, but a DNA might be more sensitive. If you have a DNA positive in that person does have low level infection, even if the antigen is not. And then I would think about trying to protect that person by treating their Hep B. Let me give you a different scenario. Patient comes in the clinic, has a negative surface antigen, positive core antibody, but a positive surface antibody. That patient, I do not routinely check a DNA in because they've got the protective metric of that surface antibody generating. And that makes sense that they've got positive antibody and a negative antigen. I do not check a DNA in every person who has a core antibody. I check it when a person who has an isolated core antibody. Those patients with a core antibody and a surface antibody both positive, I think they've had strong, robust immune reactivation or activation against hepatitis B. There's no evidence of hepatitis B, the surface antigen. I will treat that patient without doing further hepatitis B workup. So I would affirm your question, David, and the case scenario, but differentiate those two outcomes.
Yeah, thanks.
Lindsay, I'm going to pitch it back to you so we can get through to our cases, but just want to say thank you all so much for all that you do and contribute in this space. And do not let this be a reason not to treat patients with hepatitis B with weird serology results in Hep C. Rather, I would affirm and encourage you to apply this information to your practice, but also to share cases that you're concerned about or worried about with this group to help facilitate treatment of patients with Hep B, Hep C co-infection or uncertain Hep B status with Hep C so that we can support you through ECHO.
Thank you, Dr. Chastain. I agree. This is one of my favorite topics that we talk about actually in Project Echo, just because it's something that we personally get a lot of questions about, but also I just think that it's personally fascinating and so interesting. So we welcome all cases. If you have questions or,